access to psychiatric care at the district level. Now, after about 6-7 years, probably about 26 districts have access at least at the district level and several at the taluk level. Of course, simultaneously, as Dr. Mohan Isaac and others said, other larger events are taking place. But I must say that the pressure from the ground does speed up. I don't know, Dr. Ramaswamy didn't acknowledge that, but I would like to ask him at some point, how much is the pressure from the ground, from the people, from the federations, from the caregivers associations, like the gentleman who came and spoke right here. So that kind of pressure, and also facing a large group who's demanding, that makes a big difference even on the government responding. Decreased human rights violations, yes. GP doctors' orientation to CMH, community mental health. Of course, this is still something that has to be refined further. What is that specific role? Today, when Dr. Jacob mentioned that, yes, psychiatry must be practiced at the GP level, then only so some clarity is emerging. It's an area that we need to refine our, partner field staff trained. So, but the main thing is there are such a lot of now trained barefoot workers who understands how to respond to mental health problem at the ground level. They are located there, they are quite motivated people, and that's a change. Formation and strengthening of solidarity groups. Yes, that's happening, and I must say that it's an important area in our stress. We feel that we are there to facilitate something that will take on its own strength. So this is an important part of our work. I'm going to skip this is a detailing of the same numbers. I'm going to skip unless somebody asks for it. This talks about the referral in the states that we are working, stabilized, etc. Strengths. Yes, we definitely think this is a client-friendly approach. We heard a lot of discussions earlier. What does this community approach mean? So we have experienced that this is a very client-friendly because there is a link established right at the family, at the home level. And getting that trust built up is part of the quality change that happens. And then, because many of them might have, especially in Bangalore urban program where I've been involved for many years, many of these people have tried medication at some point or the other and dropped out because of various reasons. So that trust and then the motivation, persuasion to keep it up and the various other interventions that goes in. There is a focus on individual needs as expressed in consultation, but there is also a focus on determinants. Determinants, I mean, when you convert the individual needs into a sectoral need. For example, individual need is I want a job. So sustainable livelihoods. Is there access in the system? Many people said yes, they drop out without education. So skills, workable skills are limited. So how do you address the system where determinants are such? So it complements medical care. It's empowering clients towards active role and giving a voice. We had some discussion earlier that even in this group, the voice is primarily of the middle class, educated, English speaking. In community programs, through federating the leadership, etc., that voice is coming up. And they are themselves finding that to enlarge their voice, they link up with existing disability federation. Disability movement in the country has been about 25 years old. So in every state, district and state level, some level of federating of the disability movement is there. And the dialogue takes place with that federation. And in the process, they accept mental illness, the caregivers groups into that. It takes some time because these individuals are not initially articulate people. So even in federations, they don't get representation at voice level. But over a period of time, it happens, So that is the way the voice is getting built up from the ground. It mobilizes diverse resources. Panchayats have been asked to allocate sums, or collector has found from this fund certain situations. Like that, various types of resources, communities, etc. Apart from people themselves becoming part of the process. Support of dedicated mental health professionals. Yes, this is, I want to say that, I've put it down specifically to say this. I don't know if I'm preempting myself. Yeah, what I wanted to say is that our work is not anti-psychiatry. But we think psychiatric intervention meets only part of the need. It's an important part, but it meets only part of the need. In the present context where the medicalization makes it appear that it is equivalent to, the response for mental health, that's an artificial state. So I've described the various other needs and interventions are required. Future directions, issues and challenges. Yes. This is confined to a small population, our work, because even if we are able to expand through partnership, still in the large ocean that is in India, only the government is the answer. In fact, he gave 8 lakh persons intervened over, I don't know how many years, in 3 years, yeah. So that's a kind of scale that has to be responded to, so that only the government actor can do. But then engaging with the government is the big issue. Not integrated in other NGOs CPR programs. That means there are many NGOs doing community-based rehabilitation disability, but it's still not, that's the natural group who can integrate community-based mental health. It's still not done. Decentralized mental health services only in few districts, I mean further to the taluka level. Little available for destitute, that I think tomorrow is coming up. Business model of halfway homes not accessible to poor, even the limited ones available in urban context. Mental health professionals less sensitive to a holistic approach. Yeah, that's far from being achieved. Insignificant dialoguing with public health psychiatry. What we mean by that is, we came from a development approach. So we wanted to make sure that another approach is possible. But in the initial stages, we didn't want to be influenced too much by the medical thinking, psychiatric thinking. But now we are aware that, okay, there are initiatives that works, but also we need to engage with public health psychiatry. A lot of changes are happening, positive steps happening internationally, whatever. So there is a need for engaging, yes. Both sections can learn from each other, or maybe there are 3 sections, the rights groups, challenges of building a national alliance with rights groups. Yes, already the issue has been touched upon in this. Future directions for BNI and partnership. We see that one is integrating in CBR of NGOs, development programs of NGOs, influencing DMHP towards more community mental health development approach. Okay, as a skeptic, I don't know how much of what you said at the ground takes place, but even what you said is coming from a government person, the broad range of intervention, it's a great thing. So if the DMHPs can be engaged with to look at the issue more beyond the decentralized healthcare distribution to a broader approach. I heard that in what you said. In fact, I'm very pleasantly surprised to hear about the caregivers groups, federations, etc. Role of the affected in planning and monitoring services. There is a space, we say the democratic space in the national programs. In NRHM, there is the community monitoring, which is built into the NRHM. So such spaces are there. How mental health groups can get into such system level monitoring processes. That's an important thing. Sensitization of mental professionals towards CMHT. Yeah. So, I end with a quotation from Mahatma Gandhi. I think this is the positioning of all NGOs, all genuine NGOs. We see ourselves, we're not conceived mission to be that of wandering everywhere to deliver people from difficult situations. It is to show people how they can solve their own problems, how people's groups can be grown, take up their own issues, etc. Thank you.